Hi, my name is Lexi. I am a nurse here in the emergency department, and I'm completing a master's program. And my education piece that I decided to implement is education in the emergency department related to miscarriage care. Originally, I was going to kind of commandeer one of the staffing meetings and cover the information there, followed by like a short survey. But for obvious reasons, I moved to Plan B, and I'm going to film this discussion on the miscarriage care education that I'd like our staff members to have, and give a little reason why, followed by a quick survey monkey to see, I need it to tally the total number of people who've watched it. So I appreciate you taking the time to take a look at this. I'm hoping not to make it too long, but I do want it to be useful to folks. Of course, afterwards, if there are any questions, please feel free to reach out to me. I'm obviously interested in it, and I'm happy to answer things for people. So the flyer should be attached to the email that you got the link for this YouTube. Originally, it came out as 2 images, and I'm not sure that I'll be able to consolidate them into one, but we'll play with that. So the main reason that I did this is that in nursing school, we have such limited information given to us about miscarriages. We talk very briefly about it, maybe one lecture, and it doesn't really encompass like the emergency care for it. So that's why I decided for this to be a topic. We see so many early pregnancy loss patients or patients with early pregnancy loss symptoms that I felt like it would be really beneficial for most of us to have. So the main topics that I wanted to cover is the why, the what, the who, the where, all the main big questions. It is known that roughly 80% of women in early pregnancy arrive to the emergency department for pregnancy loss care if they are experiencing a miscarriage. Most people haven't established with an OB or a midwife, and folks who have find that they are in such kind of emotional distress that they don't want to wait for an appointment to see a midwife or their obstetrician. Alternatively, they have maybe run out of time because it's a Friday, and so they're unable to find them during regular business hours, and they're unable to wait till Monday. Or their symptoms are bad enough that they need to see someone more urgently. So that would be someone with very heavy menstrual bleeding, or a lot of cramping, or if it's one-sided, there are a lot of emergencies that do come with early pregnancy care also. So 20 to 25% of pregnancies are ended in early pregnancy loss. Not all of these are known pregnancies. Sometimes it happens when folks are just unable to maintain the pregnancy, but they are having like an early period or something like that. They're not quite sure what's going on. And many of them are known. A miscarriage is defined as a pregnancy loss before the 20th week of pregnancy, and most of those losses happen before 12 weeks. That second trimester loss of 13 plus weeks pregnant, it can be very dangerous for folks. The placenta is usually very well attached, and there's a high rate of hemorrhage with second trimester losses. So just be aware of that. We partner very well with our OB group, even though sometimes it doesn't feel like it, because they do take a lot of our second trimester bleeding, water broken pregnancy losses, because they're just very able to give care. They're much more well equipped for that. So the first pregnancy test is often when people start to feel connected to their baby, especially if they're trying to get pregnant. So singular positive pregnancy test is all it's going to take for someone to feel like they're going to become a mom or a dad or whatever their pronouns give them, because those are when you start to think, oh my gosh, this is real. And even a 4-week loss, a 5-week loss, a 6-week loss, to those folks experiencing that, it is already that they already have a baby. It may be that we know that this is a zygote, we know that this hasn't implanted yet, but to those patients, it is truly that they are having a baby, they are now parents. So anytime after a known pregnancy test really can trigger a lot of feelings of grief, loss, and fear. 50% or a little more, depending on your study, demonstrates some sort of chromosomal or placental abnormality for the baby. So there is something going wrong with the baby or the connection of baby to mom that is causing this miscarriage. And for a lot of people, knowing that it's likely nothing that they did that could influence this can be very comforting, because there's a lot of shame and a lot of guilt associated with pregnancy losses, when in reality there's likely almost nothing that you can do to trigger a pregnancy loss unless you're doing it intentionally. The one other thing with that is that drug use can trigger it. So if somebody is utilizing especially cocaine or methamphetamines, those could be potential loss triggers, but again, over 50% are chromosomal. The vast majority are for medically related to the baby issues. So really just trying to kind of hammer home that obviously there's something going wrong, and it's likely nothing that they did, said, or felt that could have contributed to this. I'm just going to kind of read through some of the pieces on here and expand on it on the flyer. So if you have it, feel free to follow along. And if you don't, you can just listen in and then compare later. So like I said, a miscarriage is defined as a pregnancy loss before 20 weeks, with the majority of those being before 12 weeks. That's the end of the first trimester. The losses are actually pretty infrequent when you have a patient who has a heartbeat. Once you have a heartbeat, significant decrease in pregnancy loss risk, which is great for a lot of folks. So when you see a heartbeat, that can be very reassuring. Signs and symptoms of pregnancy loss, we are pretty all familiar with. And those typically are the ones that we see in the emergency department, right? Abdominal cramping, vaginal bleeding. Those are the two main ones. Sometimes it's associated with nausea and vomiting, but nausea and vomiting is more, it's non-specific, right? Cramping can be implantation cramping or implant cramping when the body is just finally getting the yolk sac to attach, and so you can get some like implantation as the baby kind of burrows into the uterus, into the endometrial lining, and that usually happens in week 4 to 5. Can be associated with light pink spotting also. Other folks have a light spotting when they would normally have their next period. That's sometimes normal for people, but that's why we rule it out, right? We're going to rule out the scary stuff as best we can. So typically spotting is described as pink or brown, and usually bleeding is described as red. There are sometimes clots associated with that. I will caution folks that there are more than one case in the research studies and in ERs around the nation where people have vaginal bleeding and spotting, and they are passing large clots. They're bleeding through their underwear, they're bleeding through their pads. It can be really emotionally distressing to sit out in a lobby and bleed through your pads in a wheelchair. It can be very embarrassing to have to go to the bathroom and change your underwear and your pads and to sit on a bloody seat. So I would implore you to work to see if we can get their workup started in the lobby. And honestly, you might need to increase their ESI based on the emotional severity of this. If your mom is crying, if the dad is upset, if people are really, this is a highly charged situation for a lot of people. Like I said, as soon as you get a positive pregnancy test, to them, this is the potential loss of their baby. And so you may want to consider up triaging their ESI related to that. Types of miscarriages. So you've got a spontaneous miscarriage. This is also considered a spontaneous abortion, and it is the loss of a pregnancy spontaneously before 20 weeks of pregnancy. It means that there's nothing that initiated it outside of the body or the placenta or the baby. Something there happened. A missed miscarriage is when there is pregnancy loss, as in there is no heartbeat, but there are no signs and symptoms of miscarriage. This is very typically found in outpatient OB clinics and midwife clinics as compared to in emergency departments, because we usually get a singular snapshot in time, and unless you've already established a heartbeat, we don't know if there was one there beforehand or not. So a missed miscarriage is when the body has yet to recognize that the baby has passed, and therefore it has not started the miscarriage process yet. A threatened miscarriage or threatened abortion is where you have the signs and symptoms of pregnancy loss, and yet you have not had any fetal products pass, and that there may still be a fetal heartbeat, there may be a yolk sac present, like there's something indicating that the pregnancy is still existent, but there are signs and symptoms of pregnancy loss. An incomplete early pregnancy loss is when there is loss of only some of the products of conception. They've been bleeding or spotting for X amount of time, but on the ultrasound, it demonstrates that there's still a yolk sac or that there's still tissue retained. And when you have that retained tissue, you run the risk for a septic abortion. That's the parts that are going to get infected and potentially cause other issues such as sepsis and death. So an incomplete and a threatened, missed, and spontaneous abortions are all the same as early miscarriages, just at different stages and different recognition levels of the body. A complete abortion or complete miscarriage is when there is the complete loss of pregnancy and all products of pregnancy and all products of conception. So then on ultrasound, there is no evidence of a yolk sac. There is no evidence of a fetus. And this actually often takes 2 visits because there is a decrease in that level of HCG in the blood. So that's when you find that there's nothing there. You take your HCG and they recently had another HCG and you compare it and the numbers are going down. That would be a complete loss. Management options. Most typically in the emergency department, we will see expectant management. This is because we only get one picture during this visit, and you truly need more than one picture to say whether or not a pregnancy is going to be viable. The only exception to that is an ectopic pregnancy, because if there is a fetus, a baby developing in the fallopian tube, that is not viable and it can kill the mother, so that needs to be assisted surgically. But for the most part in the emergency department, you will find that we do a lot of expectant loss care, and that is watchful waiting. We have to see what the body is doing. Is it just too early and we need to retest and everything will be okay? Or is it that it's actually an early miscarriage or a missed miscarriage, or it's a threatened miscarriage, and see kind of what the body does over the next several days to see how we can best support the process of either that successful potential pregnancy or that loss. So that's the most common for us. There is medical interventions, medical management, and there are 3 most common medications. You do not have to know these, but I would at least expect you or want you to be familiar with them and have heard the names before, so that you're not completely confused when you see them or hear about them, or you see the routes that they're given, because sometimes it's a little odd. So the first medication that's most common is mifepristone, and this is given orally. It does trigger miscarriage, and it can be redosed. So it can be given again later, like single dose, double dose. This does trigger loss. So this would be like in the case of maybe a missed miscarriage, and the family doesn't want to sit and wait for 4, 5, 8, 10 days and see if the body figures it out. They're like, okay, our baby has passed. This is kind of painful. It's emotionally traumatic. I just want to take some meds. Help me pass this along, and then I'm going to work on my grieving process. Totally fine. So that's where you'll commonly see this one. Another one that's like that is misoprostol, And miso can be given vaginally or orally. So you may see one or both of those orders, and that is normal. The orders are slightly different in dosing, but you won't have to know that offhand. It's just something to be aware of. It also does the same. It triggers the shedding of the uterine lining, and it triggers contraction type pain, labor pain, or period pain. Depending on the person, it's perceived a little differently sometimes. It does trigger a miscarriage. And then the other one is methotrexate. Now, methotrexate is technically a chemotherapy agent, so use caution when handling this medication. And it is given as an IM injection. It again triggers miscarriage. So often these are done by disrupting the bindings of different enzymes, chromosomes, whatever that's being duplicated so the baby can grow, and it causes shedding of the uterine lining. So you will find that they will then, after being administered these medications, begin to have increased miscarriage symptoms. But most of these patients go home with these medications in order to be able to labor and pass their baby in the comfort of their home as compared to the emergency department. The other thing that you may see with that is pain control. You may also see nausea control. So Zofran, fentanyl, Dilaudid, morphine, all of that could be completely normal. The last intervention or the management style is surgical management. So this would be a DNC. And a DNC is done in the OR. I have seen it done a couple times very emergently within the emergency department itself, but it is typically done by an OB in the OR. It is a consented procedure. They try to do NPO times depending on how much this person is bleeding, and then they help with the facilitating the loss there. Most patients recover PACU after a DNC and then discharge home, although it is possible for them to stay overnight depending on how the procedure goes. Again, that's not something we're going to be doing, but we may be prepping that patient for the OR. Like I mentioned earlier, also, surgical management would be involved if you have a patient with an ectopic pregnancy, because they would be having management of that pregnancy removal from the fallopian tubes in order to hopefully save the fallopian tubes and help facilitate further pregnancies for that patient if they choose to become pregnant again. I mentioned earlier that our most common type of management in the emergency department is expectant management. So this section talks just a little bit about that. Our HCG and our ultrasound really tell us what's happening at that moment, but it doesn't tell us which way it's heading. So if you do an ultrasound right now and there's no heartbeat, and then you wait 1 week and the pregnancy was early enough, you may find that now there is a heartbeat. If you do an ultrasound and there's no heartbeat and you wait 1 or 2 weeks and there continues to be no heartbeat, then you are looking at a missed miscarriage. If you check the HCG and the HCG levels are increasing, trending up, then it is more likely that it could become a successful pregnancy. And if you trend the HCG and they're decreasing, this is likely a pregnancy loss. Some patients do present to the emergency department for their secondary information. If they don't have an OB, midwife, they can't get into Planned Parenthood, whatever it is, they may come in having had an ultrasound and an HCG done 2 to 3 days ago, and now they're returning for whatever reason to have those repeated here with us. That is something that can help us figure out how to best help them. Again, that HCG snapshot 2 to 3 days ago, it should be doubling. Is it doubling? And if it is, then we make one plan, and if it's not, then we make a different plan. So moving to the second page of this, what kind of care should I expect to give with an early pregnancy loss? When a patient comes in, I anticipate that most of them need an IV. They don't all have to have an IV. Sometimes a lab draw is sufficient, so you could always offer that. A lot of our medications are given orally, but if they need pain control, if they look like they're going to need IV fluids, Zofran, some of our Rogam is IV now, so you may find that that is ordered too. I always suggest an IV, but it's by no means required. Everybody has their own bodily autonomy. IV placement with a lab draw. Your lab draws, the thing you care about most are three things. One is a CBC. I want to know how anemic this person is to start out. You can have a huge amount of blood loss with pregnancy loss, regardless of the trimester, right? You remember in nursing school when you had a vaginal delivery, 500 cc's was considered normal, 1,000 for a C-section. You can have hemorrhages with first and second trimester losses also. So I want to know how anemic we are to start out. I also kind of want to know what her platelets look like because I want to know how well she's going to clot in case she does start bleeding. HCG is the second one, and that of course is your indicator for how pregnant somebody is. It's not specific. It's just anything over 5 is considered positive. Usually over 20 triggers your urine test, and this will give you a number. They're roughly correlated to number of weeks pregnant, but it is supposed to roughly double each day. You can see it more than double, and that can be completely normal for that person and that pregnancy. It may indicate something like, let's say it's quadrupling, it may indicate something like twins, or it may just indicate a body that is very reactive to pregnancy. So the range can be really wide on what's normal. And then the ABORH. So this is your blood typing. A and B, A, B, and O indicate your blood type, and your RH indicates your RH factor. A positive RH factor is pretty common, but an RH negative factor isn't unheard of. It's not uncommon. And if your pregnant person is RH negative, and your baby is Rh positive, and there is a cross-contamination of blood between the two of you, then the pregnant person can actually alloimmunize or create antibodies to Rh positive blood. When that happens, then you run the risk of having the pregnant person's body attack the next Rh positive fetus. It is unlikely to happen in this first pregnancy where alloimmunization happens, but that is called anti-D antibodies, and then the body will attack every subsequent pregnancy with an Rh positive baby. The worst part or most challenging part is that oftentimes that comes during the second trimester, which we talked about earlier. Second trimester has the highest, most difficult postpartum hemorrhages to control. And it will cause a pregnancy loss second trimester, which can be horrifying for people, so devastating. Not to dismiss first trimester, but like you make it to 18, 20, 22 weeks, and all of a sudden this horrible event is happening to you. So ABORH, HCG, and CBC are going to be your primary physiologic blood lab draws that you're going to be looking for. You may need, like I said, IV fluids, nausea meds, pain medication, RhoGAM, which can be given IV or IM. They do have both types of products now. It depends on what's stocked in pharmacy, so don't be surprised if you see it one way or the other. Just make sure that you're reading the package so you're giving it in the correct route. They may need preparation for the OR, and they may need blood products depending on their how much blood loss they have with this loss. Psychologically, your patients, not everyone's patients here, but in general, ER patients are not well cared for psychologically. And it can be very, very hard to have a pregnancy loss in the ER. Part of it is that as ER nurses, we're never trained on this. Specifics and providers, and we are trained on strokes, heart attacks, intubations. We do a lot of belly pains that we can discharge. We do, lacerations well, but miscarriage support care is just something we don't do very well. And so recognizing that in their brains, many people are losing a baby or at the risk of losing a baby. They can feel a lot of sadness. a lot of grief, a lot of shame, a lot of guilt, and all of those things are normal. They're miserable and they're normal. I always encourage my patients to take the time, regardless of gestation or pregnancy, to grieve their loss, to know that they didn't do anything to cause this loss, and that they often will be able to go on and have subsequently healthy pregnancies. Now, you don't have to mention it to them unless they ask you, but it's actually more common. It's easier to get pregnant within the first 3 months after a loss. There's been some studies that have demonstrated that actually it is, if somebody is trying to get pregnant again and they do it within the first 3 months, they are more likely to get pregnant with fewer months of trying than if they wait longer than that first 3 months, which is kind of interesting. There's no reason not to get pregnant again for most of these patients. And that the likelihood of having another miscarriage doesn't increase a huge amount by having one miscarriage. We typically recommend sending for like fertility specialist type care after a second subsequent loss. So if they have a loss and then a baby and then another loss, that's not what I mean. I mean, if they have a loss and then a loss, that second subsequent should trigger follow-up care with some kind of fertility specialist. Yeah, just a lot of reassurance that there's probably not anything that they did that caused this issue. I think I covered most of these tests that are listed here already. So ultrasound could show a fetus, could show a heartbeat, could show a yolk sac. Hopefully it's showing it inside the uterus, but it could show as an ectopic pregnancy, or it could show nothing. And that just depends on how pregnant they are and whether or not they're still pregnant. If they've already had a complete miscarriage, you're not going to find anything. If they have had a missed miscarriage, you're not going to find a heartbeat. If they have a 10-week loss, you won't find a heartbeat. If they have a 10-week pregnancy that may go to gestation, you will find a heartbeat. So it'll help give directions to our ER physician and OB care based on what those ultrasound findings are. I'll tell you a personal story. I had a loss 1 month and found out I was pregnant actually 1 month later, and I went in for an ultrasound and there was no heartbeat. And I was like, I just did this like 4 weeks ago, devastated, crying. I waited 2 weeks to go back for a repeat ultrasound, and I had a heartbeat, and that's where I got my Ariana from. So just because there isn't a heartbeat doesn't mean that there's not a chance that this pregnancy is viable. There could be that your dates are off. You could have ovulated at a weird time. There's a lot of things that can cause no heartbeat. So I try to steer my patients towards assuming that this may be a loss, and at the same time not giving up all hope until you get your repeat stuff done, because there really is just a singular picture being done on the day of their visit to the emergency department. HCG level, we talked about that. It increases every 2 to 3 days. It should be doubling. If it's not quite doubling and they're having abdominal pain, actually the concern then turns toward an ectopic pregnancy. So if on the initial ultrasound it doesn't show anything, but the HCG isn't quite doubling, the concern is that there's a restrictive force there, and it might be that it's attempting to grow outside of the uterus. So that would indicate another reason for a repeat ultrasound. It's also tracked, of course, then for decreasing levels. So that's why our patients follow up in a couple of days, is because we want them to have a repeat HCG, and that repeat HCG will allow us to know whether it's a promising pregnancy or probably going to result in a loss of some kind. CBC, anemia and platelets, ABRH, blood type, RH factor, and ROGAM we talked about, also whether it could be IV or AM. And in ACOG, which is the obstetrics group like ENA, ACOG is now having some disagreement within themselves of whether or not ROGAM is effective in first trimester losses. So later losses, traumatic losses such as a motor vehicle collision or something like that, Those types of losses, you'll more likely see ROGAM given, and in atraumatic losses or earlier losses, you may not see it given. Please defer to the OB and what their recommendations are. Usually our providers are chatting with them to make sure that our patients have follow-up, but also they are going to be asking about ROGAM. If you don't hear about it from them, please feel free to ask them and just say, hey, sometimes we give ROGAM, should I be prepping to do that? And they'll be able to give you a better idea. What do I say? This is a question I hear a lot from our ER nurses. Again, we're not trained in the emotional support of pregnant people. So what do you say? Treat the patient as though they're your family member. Be nice. Touch their hand, let them cry, encourage them to grieve their losses, encourage them to talk about it, remind them that it's normal, remind them of how many times this happens every day, not to minimize their loss, but to remind them that they're not alone in their loss. Avoiding medical terms can be very helpful, especially even if somebody works in healthcare. If you told me that I was losing my zygote, I would feel like you're so disconnected from the situation, I'd have a hard time listening to anything else that you said to me. If you said that I was probably losing my baby, that humanizes it and it makes me feel like a person. It makes you feel like you understand what it is that I'm going through with it. So phrases such as fetus, zygote, even products of conception can be really difficult for patients to hear. The other thing is anything that can somehow be construed as a fault. So things like, oh, this is a pregnancy failure, as compared to this is a spontaneous miscarriage or a spontaneous abortion, with a discussion of the fact that a spontaneous abortion means miscarriage and not that you did anything to abort your baby. Things you can do, like I've already mentioned at least 50 times probably, is to encourage the loss grievance process, letting them know that it's okay to be angry, it's okay to be frustrated, it's okay to be sad, it's normal to cry, it's also normal not to. It depends on that person and how they grieve. I look at both parents or both parties if they're there and encourage both of them to do this. We talk a lot about the pregnant person, but the pregnant person also has a partner who thought that they were going to be a parent. And while it's important to make sure we're taking care of the pregnant person physically, it's also pretty important to take care of both parties psychologically. And there's one of my favorite things that I use with the patients is I use I wish statements. And I wish statements recognize that we didn't find something that we like, that can be really hard, and also don't give false hope. So things like, I wish we found a heartbeat, or I wish this wasn't happening to you, or I wish every pregnancy was just viable. Or, some sort of statement that recognizes what this person is going through, humanizes it, and allows you to connect with them. My favorite, it's so easy, is the I wish statements. You go in and it's literally, what did you wish would happen? I wish that we'd found a heartbeat. I wish your HCG was doubling. I wish you weren't cramping right now. I wish you were comfortable. But saying it genuinely. It can be very humanizing. Another question I get a lot is, what do I teach them? So main discharge teaching is what to expect. This is what patients say so much in the studies that they don't get. What can you expect? So if this person is having a miscarriage, and I usually present it that way, if this is in fact a miscarriage, you can expect to have increased abdominal cramping. Now, every person feels that differently. It could be heavy menstrual cramping all the way to labor pain. Both of those are normal. I say that they are going to expect increased vaginal bleeding. I let them know that that can include clots. I usually have people say clots, Postpartum, it's usually the size of a lemon, but if you are passing large clots or needing to change your pad every 1 to 2 pads an hour for more than 2 hours, you should be coming back in. I also tell them that it could be clots and they might even pass a small fetus or a small baby. And I use those words so that when it happens, if it happens, they don't feel totally blindsided by this. I mean, I know that we all to some degree know that that's what's going to happen, but if you're a patient, for some reason, you don't think that that's what's going to happen. And so you can be very off-put by that. So yeah, I tell them to expect cramping. I tell them to expect pain and discomfort. I tell them to expect bleeding and how much, roughly. And I tell them to expect clots. Reasons to return. These are the big ones, right? 1 to 2 pads an hour with vaginal bleeding, please come back. Any sort of lightheadedness, dizziness, syncope, any other symptoms of blood loss, please come back in. If they are having pain that is uncontrollable at home, please come back in. And the big one is if they have any fevers. So this is that septic abortion or a missed miscarriage. A little piece of product is left behind and causes an infection. So fevers are another good reason to come back in. I also encourage follow-up with their OB or their primary care or their midwife, whoever it is, whoever they can follow up with in the next couple days, 2 to 3 days for repeat HCG. Sometimes they'll want a repeat ultrasound then, but I leave it up to OB and PCP because they may want to wait a week or two before they get a repeat ultrasound. And then finally, local resources. So the first one I put on here is a really big group. It's called the Perinatal Support Group, and it's located in Washington. It's all of Washington. It has peer support in different places. It has online meetings. It has access to in-person meetings. There's a phone number here that people can call to get connected. I do believe that it is Spanish friendly, like they have Spanish speaking staff. There is also an email to help connect with the teams there. And then I put on here the general website that we could refer patients to. The other option that I have sometimes provided to people is the Evergreen Perinatal Behavioral Health Services. This is also sometimes called the PMAD Clinic, which is the Perinatal Mood Disorder Clinic. And the phone number is on here. It's located in Coral for right now, although I have heard that they will be moving to another location. And this is more for the psychological services related to it. They don't necessarily have like support groups, but they do have perinatal related mental health nurse practitioners that take and see patients related to the mental health surrounding pregnancy, gestation, postpartum, etc. They do a really good job. They do medication management through there if needed, etc. So that is what I have for some miscarriage education for you folks. I really appreciate you making it all the way through because I know it was a long video with a lot of information on it. Please feel free to reach out to me if there's other questions or if you have any concerns about what I said, or if there's anything that I can do if we do education in the future to help make it better or more applicable. But yeah, overall, thank you so much, and I hope you have a great rest of your day.